Hi everyone. This is our video for immunological disorders that we were not able to have to discuss during class today. In this first slide, just disregard it. I had created a case study through this program and we were going to quote unquote play a little bit with it, but I haven't taken this out. So disregard anything that you read about Kahoot. So let's get started on some immunological disorders, and we are page 993 in the book, starting on chapter 62. So the first thing we're going to talk about are allergic reactions, and allergies are defined as immune-mediated responses to a foreign allergen. They're often characterized by an inflammatory response to this allergen. These exposures can lead to a systemic response that can impact multiple organs in the circulatory system. The slide lists different types of environmental allergens, and these can include inhalants that are like your pollens, your molds, and things that you might ingest, food or drugs, things that might be injected into you, such as an animal bite or an insect bite, and then contact things such as dust mites, chemicals, animal dander. The book also mentions the term atopy, which is a genetic tendency to develop allergic type of concerns, and it's an IgE response that is exaggerated and is not necessarily at the same degree as the exposure of what the person was exposed to. On those beginning first few pages, be sure and review the pathophysiology of immunological responses. We're not going to go over that. The next thing we're going to talk about are hypersensitivity responses. There are a variety of responses to different allergens. If we review, we know that there's cellular and humoral immune responses after an initial exposure to a foreign substance. So some key cell types that are involved in allergic responses include histamine-containing mast cells and basophils, as well as granular eosinophils. And there are 4 types of immune responses to allergens, and they're characterized by whether they are dependent on circulating antibodies, which are the types 1 through 3, or on a cellular immune component, which is type 4. So let's go over these briefly. Type 1 is when the immune system sees the allergen as foreign. IgE binds to those mast cells, which are found primarily in the skin, the GI tract, and the respiratory tract. And this causes capillaries and venules to dilate, and the IgE activation causes a cellular excretion of inflammatory mediators that can take place in seconds to minutes after exposure. A second type 1 reaction is anaphylaxis, and unlike atopic diseases, which are more localized, this reaction will cause a systemic effect, and your patient can have hypotension, bronchospasms, angioedema, and urticaria. Type 2 involves the activation of IgM and IgG, and these are humoral molecules that bind to the foreign antigens and activate a serum immune complement sequence. You can see destruction of cells, and the response to this destruction of cells can be cytotoxic to other parts of the body. For example, Rh incompatibility, and then a condition called hemolytic anemia. For type 3, this requires IgM and IgG. These are combined complexes that deposit in various tissues, and they activate a multi-inflammatory response. The reaction may not occur for 2 or 3 weeks after exposure. So an example of this might be like a pneumonitis after an inhaled allergen or drug reactions. And then the fourth is a cellular immune response, and this is cell-mediated delayed type immune responses. And these cells are T-cell dependent reactions and usually begin in the skin. And a classic example of this is a contact dermatitis. So all of these treatments are going to be specific to the symptoms that you see. Initial evaluation is going to start with your clinical history, and any testing is going to be based on how your patient presents. Management of all these conditions will require symptomatic relief and then prevention of exposure in the future. Treatment will be both symptom control and could possibly be immunotherapy, which will be overseen by an allergist. On this next screen, if we were in class, I would play this, but I found an interesting hypersensitivity overview video that I encourage you to look at. It's a couple of minutes long, but I thought it kind of wrapped a lot of different things up. But we won't play that in this video, but just click on that and review that. So the next thing we're going to talk about is rheumatoid arthritis. And it's a chronic progressive inflammatory disease that we know can affect the synovial joints and can impact other organs. In your book, Healthy People 2020 has three objectives for this debilitating condition. One is increasing the proportion of adults with chronic joint pain who have been to see their healthcare provider to improve symptoms. So they want more people in being evaluated. Two, they want to increase the proportion of adults with physician-diagnosed arthritis who have had effective evidence-based arthritis education as an integral part of the management of their condition. And three, they want to reduce the number of adults with physician-diagnosed arthritis who find it very difficult to perform specific joint-related activities. So those three objectives are in your book, but a little bit more about RA and its signs and symptoms. So we know that it's a peripheral symmetrical polyarthritis and impacts patients mostly in the morning with stiffness for greater than an hour. Joints affected are typically your knees, your hands, and your feet. And affected joints can be painful to pressure, they can be swollen, and they can be partially immobile. Eventually, these joints appear increasingly deformed and rigid. If you look at the diagram that's here on this slide, it talks about the different joints that are found in the hand. So you have the proximal interphalangeal joint that's in the middle, the MCP, which is the metacarpophalangeal joint at the base of the hand, and then I believe the DIP is the distal interphalangeal joint. So just so that you know where on someone's hands that those are. These are some graphics of RA patients. You can see this poor person, how deformed their hand has become, and then see what the hand looks like on x-ray. And as a drawing, you can see the healthy joint here, how it has cartilage and meniscus, and it has the synovial fluid that looks intact. The bone is smooth. On the right side, you can see that the bone is very jagged. We have swollen and inflamed synovial membrane. The cartilage is wearing away, and there's this decrease in joint space here. So that's just a graphic for you. When you're going to diagnose someone with RA, the preferred initial testing for this condition is a measurement of peripherally circulating rheumatoid factor, and this is an IgM class antibody that binds to the Fc portion of the IgG molecules. These tests are going to provide both a qualitative and a quantitative info that is useful in correlating with other physical markers of RA. So the rheumatoid factor is not diagnostic for RA, and so you'll need also to check for SED rate or a CRP to assess for inflammatory states. Management of RA includes conservative measures and then leading more to aggressive management. Your goal is to reduce pain and inflammation and to preserve joint function. Sorry, I had a call. This may be a repeat, but goals of management is to reduce pain, inflammation, and do what you can to preserve joint function. Early interventions are physical and occupational therapy, any modalities that will help the joints to feel better, whether that's heat or cold, exercise, rest, assistive devices, splints, chiropractic adjustments, weight loss, and meditation. Pain management, of course, is key in managing rheumatoid arthritis, as we mentioned, and there are several different classes of medicines that can be used. Analgesias such as Tylenol or capsaicin cream or gel applied to the joints, or Tylenol. Other NSAIDs include aspirin, and remember though that different NSAIDs have different side effect profiles, so you need to be aware of which ones you're prescribing, such as your Advils, your Voltarens, um, Celebrex, any of those type of things, and individualize it based on your patient's needs and your comorbidities. Steroids can play a part, whether it's orally or intra-articularly, to help with rheumatoid arthritis. And then you have your biologicals that are include Plaquenil, methotrexate, and then your tumor necrosing agents that are examples of Humira. So, one case study, I know we can't interact, but let me go over this with you. One case study that I left in was you have a history of a 20-year-old female who's had fatigue, anxiety, palpitations. She's recently delivered a baby, and she's seeing her doctor, who believes that all of her symptoms are stress related, and she's encouraged to rest. Her symptoms worsen. 2 years later, she develops abdominal pain, and her doctor sends her to an internist 50 miles away, and based on her age and symptoms, feels it's her gallbladder and tells her to eat a low-fat diet and practice a healthy lifestyle. Then, 5 years after the symptoms started, she's pregnant with her third child. She has premature contractions, fatigue, headache, swelling to the legs, had to take a leave from absence, and delivers her baby boy. After the birth of this little boy, she has swelling to her ankles and knees, joint pain, elbows. She has difficulty climbing steps, dancing, etc. Rest and over the counters help with her symptoms. Winter brings a cold intolerance, and she has concerns with her hands. Um, they're painful, they're stiff. This primary care sends her to a rheumatologist, and he can't say definitively that she has lupus. He prescribes naproxen for the joint pain, and then as the seasons change, she develops a red rash that's itchy after being in the sun. She has some sores on her arms and legs. She continues to have joint swelling, pain, and fatigue. So her labs, we can see these here. They eventually, you can see that uh, her hemoglobin was low at 10.5. Her white count was normal. Her platelets were normal. They did, ANA was normal. Her anti-DNA antibody test was elevated. They did do a skin biopsy and determined that she had small vessel vasculitis. She was put on prednisone and then started on nabut- nabumetone before steroids were stopped, and this began to help with her inflammatory issues. So I wish we could have some more discussion about that, but you can see how this young mother had symptoms for over 5 years before she was truly diagnosed with, or her symptoms given a name, shall we say. Next, let's talk about systemic lupus, erythema, SLE. And so there are certain diagnostic criteria for this condition. We know that it's an inflammatory autoimmune disease that affects many organs. And so we have a couple of slides that you have to have at least 4 of the following 11 criteria met in the absence of drugs or other disorders known to possibly cause these effects. So you have to have non-erosive arthritis, usually in 2 joints, photosensitivity, oral or nasal ulcers, a malar rash on the face typically, a discoid rash with these raised or red patches, serositis, which is inflammation of the pleura or pericardia, renal disease, a hematological issue such as hemolytic anemia, leukopenia, lymphedema, low platelets. We have one more slide. Neurological diseases such as seizures or psychosis not otherwise explained by iatrogenic or metabolic causes, positive ANA, and then other immunological antibodies. In these patients, you're going to see malaise, fever, could have anorexia, unplanned weight loss, vision and conjunctiva swelling, sleepiness and depression, swollen joints, shortness of breath, pain on inspiration, and then vague abdominal concerns. On the skin, one classic finding of lupus is a butterfly rash. These patients can have alopecia and scalp exanthems. They can have splinter hemorrhages of the fingers, lesions on the fingertips or toes. Lymphadenopathy may be seen. There can be scarring and inflammatory lesions that are associated with discoid lupus, and Raynaud's phenomena is seen in approximately 40% of the patients. So here are some videos of skin conditions that you may see. That malar rash, I'm not sure if you can see my icon while we're recording, but there, that butterfly look on the cheeks and across the nose. And then also, these are some findings of what you might see of someone's fingers that has lupus. And you can see all the redness there along the bases. You can't see maybe any unnecessarily splinting, but you can see like on this fingernail that maybe some ridging. So just some things to be aware of as you're doing your assessment. Musculoskeletal findings are going to be swollen joints. Swelling doesn't follow a pattern regarding which joints are affected. The joint pain may be asymmetrical. It may not cause any deformities. It can be migratory. And 90% of these cases are often the presenting case before lupus is diagnosed. Some neurological findings include impaired thought processes. Patients may report lapses in logic, and these are not sometimes even evident on like many mental exams. There can also be evidence of peripheral paresthesia and diminished deep tendon reflexes. Cardiac wise, there could be systolic murmurs, and there can be distended jugular veins due to cardiac failure. GI, they may have sores in the mouth or in the nose. These patients may have right abdominal quadrant tenderness, and they may also have enlargement of the spleen. Hepatitis is a common finding, and then there may be right lower quadrant pain, suggesting that there is right colon enlargement. Management of these patients includes good symptom control. Non-pharmacological activities may include PT, OT to help promote function and prevent mobility issues. Heat and cold, whatever feels best to your patient. It's important to explain to them that exercise can reduce pain and inflammation, and also rest is important to decrease pain and inflammation. Emotional support can be beneficial, and referral to a support group may be needed. Medication-wise, antimalarials such as hydroxychloroquine, which has been very much in the news lately, is part of standard of care. Belimumab is a newly approved biological, and the brand name for that is Benlysta. Plaquenil is a very popular drug with lupus, and then also the use of steroids or cyclophosphamide for refractory symptoms may be used. So the last part of this video, we're going to be talking about HIV and AIDS, and these conditions are going to be, you're going to partner with an infectious disease doctor that is primarily going to oversee their care, but just so that you're aware, should someone present to your practice. More than 1 million people are living with HIV in the U.S., and approximately 15% of them are unaware that they are infected. One of the things that the book mentions is an opt-out HIV testing that has been used to increase overall HIV testing rates. And what this means is that participants are included in testing unless they give express um, decision not to be tested. Um, so we know that this condition impacts dendritic cells in the Langerhans cells, and they're the earliest cells that are seen with HIV. And after infection, these cells bind to CD4 T cells. And once HIV infects the individual, these healthy CD4 T cells, then HIV begins to replicate. There are different stages of infection, the first being the acute retroviral stage, and this is the primary infection period. The next is the asymptomatic stage, including the window period before they seroconvert, and then the symptomatic stage, and this is when you may see more wasting, infections, progression of to an AIDS syndrome. And clinical presentation, although the symptom profile is very broad, it's important to keep the diagnosis in mind as early treatment leads to better health outcomes. But some of the early symptoms are flu-like, 6 days to 6 weeks, skin changes, purplish colored spots on the skin, which could be indicative of a Kaposi sarcoma, a non-productive cough, shortness of breath, fever that's been present for several days or weeks, and then weight loss, night sweats, fevers, chronic diarrhea. Um, in the acute infection phase, greater than 8% of patients are symptomatic. Fever can be seen in 90% of patients. They may have pharyngitis, malaise, headache, cervical lymphadenopathy, and night sweats. However, the majority of patients that are acutely ill with an HIV infection are asymptomatic. Some of the things that we talked about or include this as well: persistent lymphadenopathy, pulmonary issues. You may notice decreased breath sounds, shortness of breath, a non-productive cough, fever, or night sweats. They can have localized Candida infections such as thrush, Kaposi sarcoma we talked about of the skin, sexually transmitted diseases, and these increase the likelihood of HIV transmission. These patients can have weight loss, and then they can also have cytopenias such as anemia, low white count, and low platelets. I think we talked about that one. So, some diagnostic tests that are run for HIV include the ELISA, which is an initial screen for antibodies. If that is positive, then you would go to a confirmatory Western blot. You can check an RNA viral load and a DNA assay for little ones, and this is going to detect if there's infection before there's been seroconversion. Another test is the OraQuick, which is an advanced OraQuick Advanced, which is a rapid HIV test designed for use with oral fluids. And then at diagnosis, T cell subsets are used to determine if the CD4 T cell count and the HIV viral load with genotyping for antiretroviral resistance mutations. So sorry that I read all that, but as I said, this is something that you are likely not going to, you might have your concerns and you might do some initial tests, and if you start developing positive results and you're going with the HIV diagnosis, then referral to infectious disease needs to be made. Some key principles of taking care of these patients is the initial disclosure of HIV status to the patient and sexual partners. And on this slide, each state has specific reporting guidelines, and I've included the link for that for within the state of Kentucky. Initiation of drug therapy is essential to suppress the virus and to decrease any comorbidities, and then also monitoring of the viral load and the CD4 T cell count. On page 1038, there is the iceberg of care for HIV, and so I encourage you to review that of all the different modalities that would go into the care of an HIV patient. And then on page 1039, table 63.3 has interpretations of different lab tests for newly diagnosed HIV patients, so you can have a better understanding of that. And then there's also on that page, I believe, an HIV testing flowchart for HIV infections. So review those. Um, Medications include nucleotide reverse transcriptase inhibitors, um, protease inhibitors, fusion inhibitors, integrase inhibitors, and chemokine receptor antagonist. And I'm not don't feel comfortable with any of these medications because this is not an area that I've studied on, but just to be aware of the class of medications that could be used for treatment. Um, I've also included on this link the guidelines for antiretroviral agents in adults and adolescents living with HIV. So if you check on that link, it has more information on medications. Um, with these conditions, there's concerns for opportunistic infections. Virally, that could be a cytomegalovirus, herpes, a varicella zoster virus, and then leukoencephalopathy. Bacterial could be tuberculosis, fungal pneumocystis, pneumonia, Candida, histoplasmosis, and protozoal. You have cryptosporidosis and toxoplasmosis. Um, for AIDS, the diagnostic criteria is HIV infection with peripheral CD4 T cells less than 200, someone with HIV infection with opportunistic infections or other AIDS defining illnesses, and then HIV drug resistance testing typically done for all patients before initiating therapy to guide their antiviral regimens. Monitoring includes follow-ups more frequently, especially when the heart protocol, which is a form of treatment, could be started, or any new medications to assess for the response to therapy, as well as drug tolerance. You would follow with a CD4 TC cell count every 3 to 6 months, and then check HIV viral loads when initiating or switching antiviral regimens, and at 2 to 8 weeks to determine response to therapy, and then monitor every 3 months, 3 to 4 months. Um, I think that is the end of this video, so I thank you for your time.